This is a pre-recorded presentation, so the presenter will not be taking any questions. However, all questions asked during the live presentation, along with answers, are included at the end of this presentation. To learn more about our upcoming patient and family conferences in your area, please visit aamds.org/conferences. To view other recorded presentations or to register for other live online learning events, please visit aamds.org/learn. Welcome to our live webinar titled, What is Pure Red Cell Aplasia? Understanding Diagnosis and Treatment. Thank you for joining us. My name is Angie Onifray, Director of Patient Education at AAMDSIF, and I'll be moderating the presentation today. As we get started, I would like to acknowledge generous support of patients, families, and caregivers providing support for this webinar program. Today's presenter is Dr. Maciejewski. Dr. Maciejewski has attended medical school at the Medical School of Charité of Humboldt University in Berlin, Germany, receiving both his medical degree and doctorate from the Institute for Medical Immunology at Humboldt University Medical School. He completed his internal medicine residency at the University of Nevada School of Medicine in Reno, Nevada, and his hematology fellowship at the National Institutes of Health Medical Center in Bethesda, Maryland. He also completed his postdoctoral research fellowship at the hematology branch of the National Heart, Lung, and Blood Institute in Bethesda, Maryland, where he later served as a staff scientist before joining the Cleveland Clinic in 2001 as a staff physician and the section head of experimental hematology. In January 2009, Dr. Maciejewski was appointed chairman of the Department of Translational Hematology and Oncology Research at the Tuskegee Cancer Institute within the Cleveland Clinic. He is also a medical advisory board member for the Aplastic Anemia and MDS International Foundation. With that said, it is my pleasure to welcome Dr. Maciejewski.
Hey, thank you, and thank you for this introduction, and it's a pleasure to be able to deliver to you maybe a small informative vignette about pure red cell aplasia for those who are affected by this disease or want to know more about what to do, how to diagnose, and how to deal with this disease. So I will start right away with the introduction of the problem. As you know, in general, and this applies not only to pure red cell aplasia, to all bone marrow diseases, that the cytopenias, the decrease in individual cell lines, whether platelets, white cells, or red cells, can be due to multiple factors, but conceptually we can divide them in two main categories, namely the, if you wish, production cytopenias, the production problems, and the destruction or loss cytopenias. And, generally, the bone marrow failure are the production cytopenias. In some of them, there might be a combination. But conceptually, it's very important to understand that aplastic anemia, pure red cell aplasia, and neutropenia, as well as megakaryocytic thrombocytopenic purpura, a disease like pure red cell aplasia, but affecting not red cells, but platelets, all these conditions are associated with depressed production versus, of course, any of these lineages, either as a pancytopenia, the decrease of all lineages in blood, or a single lineage cytopenia, decreases in individual cell lines, can be also due to production, to destruction or loss of blood. For instance, patient can become anemic due to major bleed, or for red cells, hemolysis. For platelets, patient can be thrombocytopenic, have low platelets due to the fact that they're not producing, but the destruction or consumption cytopenias would be due to the fact that the platelets are being destroyed, either taken up by enlarged spleen or destroyed in circulation by immune factor. So to that end, this conceptual subdivision is very important as an initial workup of cytopenia. Now, the cytopenias can be divided conceptually as pancytopenia, which is associated with aplastic anemia where two lineages of blood, namely either platelets or white cells, or platelets and red cells, or white cells and red cells, in any combination, or all three are affected. This disease is clearly distinct from pure red cell aplasia and other so-called single lineage cytopenias, whereby in aplastic anemia we envision that the defect occurs at the level of stem cell, versus in the single lineage cytopenias, the defect, the mechanistic problem occurs at the level of committed progenitors, not the stem cell, but more mature cells already specialized in one direction, namely either producing platelets or either producing neutrophils or either producing red cells. Thus, it's explained why this more limited defect in pure red cell aplasia or in idiopathic neutropenia is more restricted, and other lineages per definitions are not affected. If it were a stem cell that is affected, then obviously we would see a defect in all lineages like we see in aplastic anemia. Now, of importance is also that all bone marrow failure syndromes, including myelodysplastic syndrome, PNH, or aplastic anemia, overlap to some degree, and this is a case of pure red cell aplasia as depicted here, which clearly overlaps with a little bit with aplastic anemia or potentially with LGL. LGL is type of condition, low-grade lymphoma or lymphoproliferation, which is associated with immune cytopenias, including in 20% pure red cell aplasia or neutropenia in 60 to 70% of patients. Thus, there is an overlap that is clinically important because it might affect how we think about the therapy and diagnosing this disease. And of course, conceptually, the distinction from the pancytopenia, where we know that the defect is at the level of stem cells versus it is at the level of more specialized, we call it in hematology, committed progenitor cells, which specialize differentiated into those cells that produce either red cells. This is the case in pure red cell aplasia, or neutrophils. This is the case of idiopathic neutropenia, or platelets in the case of megakaryocytic thrombocytopenic purpura. Now, the distinction of the production versus destruction or utilization, if you wish, cytopenias on the laboratory level can be made based on measurement of some simple tests, including for pure red cell aplasia or anemias, of course, reticulocytes, which are young red cells, and obviously if there is a production problem, the young red cells will be severely depressed, versus if anemia is due to bleeding or destruction, then the bone marrow will respond to this increased demand and try via what we call a feedback signal to produce more red cells, in which case reticulocytes, the young red cells, will be found in blood in higher numbers. So the high reticulocyte count highlights the fact that this is not a production problem, but the destruction or utilization problem, including bleeding. There are other parameters such as bone marrow cellularity and bone marrow distribution. Obviously, if there are no red cell precursors in the bone marrow, then it is more likely that there is a production problem in the destruction or bleeding. If you look at the bone marrow, you see increased precursors of mature red cells in the bone marrow, highlighting that the bone marrow tries to respond to the increased demand and up modulates or increases the production. Now, there are other parameters that help us to distinguish destruction, and I am speaking now specifically for red cell aplasia. For example, haptoglobin and LDH. If red cells are being destroyed, such as in autoimmune hemolytic anemia, whereas there is usually no problem with the producing cells, but the cells being produced and being recognized in the circulation and destroyed, we have decreased haptoglobin and increased LDH. So in production cytopenias, reticulocyte count, or in production disease of red cells such as pure red cell aplasia, reticulocyte would be low and erythroid precursors would be decreased in the bone marrow, versus if anemia is due to bleeding or destruction, we would see increased erythroid precursors in the bone marrow, we would see increased reticulocytes, and we will see decreased haptoglobin and increased LDH. Haptoglobin and LDH indicate destruction of red cells in blood. I'm going to move forward to the next slide, which of course is a result of conceptualization of these simple facts that I listed before, namely that if we find a patient with anemia, I think a major distinction is, among other parameters, obviously if a patient is bleeding profusely outside of the body, we are able to easily recognize it. But in other facts, when bleeding occurs in the GI tract or is more subtle, then of course at the beginning we see anemia and we need to figure out what is the problem. Reticulocytes are very helpful, in my opinion, because high reticulocytes or normal reticulocyte would indicate that the bone marrow is producing red cells, versus if reticulocyte count is very low, the problem is more likely the production rather than loss of red cells via bleeding or destruction. Now, so if reticulocyte count is high, it sends our thinking, our diagnostic procedures towards different direction, namely to diagnose either hemolysis, bleeding, or increased size of spleen, which is associated, we call it hypersplenism, which sometimes can be associated with greater destruction of red cells in our body. Now, versus reticulocyte count is low, the young red cells, the baby red cells, if you wish, it indicates that the production is not sufficient. And of course, it opens a whole different diagnostic approach. Namely, we have to first rule out simple conditions, and I'm sorry for the mundane word simple. It is not that they are not serious and don't affect patients, but in terms of the conceptualization and treatment, they appear simpler, such as nutritional anemias or renal anemia. Patients with kidney failure sometimes develop an anemia that is due to production of erythropoietin, low production of erythropoietin being a hormone that regulates production of red blood cells. This hormone is made in kidney, and therefore patients who have impairment of kidney function usually produce less of this hormone, leaving the bone marrow unstimulated to produce more blood. This is a condition that is, of course, easily recognizable by measuring the erythropoietin levels and also seeing that the patient has or has had or is developing a kidney problem. Versus nutritional anemias, including B12, folic acid, iron deficiency, and many other nutritional deficiencies such as copper deficiency or thiamine or pyridoxine deficiency, all of which could be associated with some degree of anemia and have to be excluded as because the implication, of course, of this diagnosis would be a simple supplementation either of copper in the case of copper deficiency or iron in case of iron deficiency or B12 or folic acid, etc. Now, there are other conditions where the production by itself is affected, but not due to nutritional deficiency, is of course anemia of chronic disease, which occurs in patients who have other serious conditions, and the bone marrow is impaired in producing them because the body, simplistically speaking, has to deal with inflammation or infection of other conditions that inhibit bone marrow from optimally producing red cells. Now, the most important portion is most important diagnostic distinction is, of course, identifying other hematologic diseases which could be associated with anemia. In our case, now obviously, if there is anemia is not isolated and platelets and white cells are depressed, we would not be thinking about pure red cell aplasia. We would be more thinking towards diseases such as aplastic anemia. But if red cells are only affected, then we have, of course, to make sure that there is no other hematologic disease that would affect the production of red cells in indirect way. Such diseases include myelodysplastic syndrome, leukemias, and lymphomas, in particular chronic lymphocytic leukemia, as well as myeloma. Now, in this so the bone marrow biopsy or observation or analysis of blood could help to establish that the patient does not have any of these three conditions indicated here. And sometimes the differential diagnosis might be difficult. Reticulocyte count might be low in all of these conditions. The usual size of red cells should be normal in pure red cell aplasia, but would be elevated in MDS. This is a value that you find on the blood sheet, which is called MCV. So typically, MCV is normal or low in patients with pure red cell aplasia versus would be elevated in patients with MDS. Now, sometimes it's obvious that the patient has history of chronic lymphocytic leukemia or lymphomas, and these can, of course, be associated with red cell aplasia and production problem. And, of course, the important distinction is then that we would have to treat the primary disease first before we would expect the improvement of red cell of anemia. Now, once we know that we deal with a condition that resembles red cell aplasia, or also called pure red cell aplasia, the pure referring to the fact that other lineages in blood, namely white cells, called also as neutrophils, and platelets are not affected. Thus, I call it isolated reticulocytopenic anemia, or pure red cell aplasia, can be divided in cases which are inherited, usually present in children or younger adults, and by far less likely in adults, because we would expect that this condition would have manifest themselves early in life if they are inherited with genes. So these are the inherited bone marrow failure syndrome, with Diamond-Blackfan anemia being the most important example of this, but they are Diamond-Schwachman anemia and other anemias that could present as red cell aplasia or pure red cell aplasia, and of course the distinction to acquired pure red cell aplasia. Now, the acquired pure red cell aplasia can be either secondary due to these conditions such as chronic lymphocytic leukemia, LGL, MGUS or myeloma, Good syndrome, and drug-induced, or associated with other conditions. It can be also acquired via viral means, namely in form of transient aplastic crisis. Simply speaking, it is an infection with a rare virus, B19 parvovirus. So, to be correct, the virus is ubiquitous, but in certain circumstances, under certain medical conditions, can infect humans later in life and cause a disease which we call pure red cell aplasia due to transient aplastic crisis. Essentially, the virus, B19 parvovirus, is very specific for attacking and destroying red cell precursors in the bone marrow, not white cell precursors and not other cells or stem cells, explaining why only red cells and patient develop only severe anemia. Now, normally we do not have pure red cell aplasia. Normal adults, healthy adults, are very likely to develop B19 associated pure red cell aplasia due to the fact that its B19 parvovirus is often acquired early in life in form of an infection that is mostly asymptomatic in children called the fifth disease or slap-chick disease. And once children go through this condition, sometimes parents even notice that they have it, they develop lifelong immunity. They, if you wish, are self-vaccinated. And this self-vaccination, of course, is associated with protection. Thus, most of the adults who went through B19 parvovirus infection in form of slap-chick disease or fifth disease in childhood will never develop pure red cell aplasia due to B19 parvovirus. Under certain circumstances, and the risk groups include individuals infected by HIV where they are immunocompromised, those who have inherited immunodeficiency, and those who have immunodeficiency and those who have either thalassemia or sickle cell anemia, like Haitian population, they are predominantly susceptible to B19 parvovirus infection. So this is easily diagnosed and treated, and I will allude how do we treat and diagnose this condition a little bit later on, or what is needed to rule out that one does not have B19 parvovirus. Now, I mentioned immunodeficiency, and I noticed that here as a secondary form of pure red cell aplasia, we see association in patients who have combined variable immunodeficiency, a common, often less symptomatically or less obvious in severity syndrome that is genetic. These patients are impaired in response to in production of antibodies, and therefore, for whatever reason, are more susceptible to development of pure red cell aplasia. One of the clear manifestation of immunodeficiency, thymoma, and pure red cell aplasia is so-called GOD syndrome or Good syndrome. Now, the most common, by far most common, form of acquired pure red cell aplasia is idiopathic pure red cell aplasia, as well, and by far less common but possible autoimmune pure red cell aplasia. Autoimmune pure red cell aplasia is related mostly due to antibodies to erythropoietin, a hormone that I described earlier as one that regulates bone marrow to produce red cells. In rare circumstances, sometimes in patients treated with erythropoietin, antibodies are developed, and therefore this hormone is neutralized and does not stimulate bone marrow to produce red cells. Most commonly, pure red cell aplasia is an autoimmune disorder mediated by immune cells called T cells, and we refer to this form as idiopathic idiopathic pure red cell aplasia. A rare distinct form of idiopathic pure red cell aplasia mediated by T cell is a thymoma-associated pure red cell aplasia. So, what do we do what tests are important to diagnose pure red cell aplasia? One of the important tests is, of course, differential, and usually anemia is normocytic. In other words, the red cells are regular size, not enlarged or decrease, and platelets and neutrophil counts are normal. We looked for cells called LGL, which are called large granular lymphocytes, because it would point us to the presence of LGL condition that I am going to allude a little bit later. And of course, we need to make sure that there is no other malignant cells such as chronic lymphocytic leukemia cells circulating in blood. The bone marrow exam, the reticulocyte will be invariably low in pure red cell aplasia or very low, and the bone marrow exam typically would show lack of erythroid precursors, but other lineages would be unaffected. Also, there would be no leukemic cells or no other cells suggesting additional bone marrow condition. In cases of virally mediated B19 parvovirus mediated pure red cell aplasia, as I mentioned, called transient aplastic crisis, in this case, the bone marrow contains cells which are very typical, strange-looking erythroid precursors, which are called giant pronormoblasts. Giant pronormoblasts are erythroid cells. These are these cells that produce red cells that are full of the virus, swollen, and therefore we can find them in bone marrow, sometimes in bone marrow of these patients who have B19-mediated pure red cell aplasia, but not in other cases. Now, the CT scan might be helpful to rule out that patient have thymoma. As you remember, I mentioned that thymoma is frequently associated with pure red cell aplasia. The association between thymoma, this benign tumor of thymus, and pure red cell aplasia on mechanistic level is not clear. Needless to say that pure red cell aplasia often accompanies thymoma, or thymoma accompanies pure red cell aplasia, and it's important to know because removal of thymus is usually therapeutic. US ultrasound of abdomen might reveal enlarged spleen, which would be not typical for pure red cell aplasia. In fact, in pure red cell aplasia, spleen should not be enlarged. It points rather to hypersplenism, which is a sign of many other diseases, but not pure red cell aplasia. Sometimes we can obtain flow cytometry on blood or bone marrow, which help us to diagnose either LGL or CLL, these leukemic disorders of lymphocytes that are often associated with red cell aplasia. Another test to that end is TCR, T-cell receptor skewing by flow cytometry or by DNA testing. Now, auxiliary tests that might be important to distinguish several different or unique types of red cell aplasia include testing for immunoglobulin level to rule out immunodeficiency, testing of EPO level to rule out problems with kidneys and renal anemia. If LDH should be typically normal, if LDH is elevated, then it points towards hemolysis and destruction of red cells. If it's elevated, it also might point out to CLL or to the presence of LGL. And haptoglobin, which should be normal and not low. Low haptoglobin would indicate that there is hemolysis. Now, for B19, to rule out B19 parvovirus, and this is important, patients who had the infection in childhood have B19 parvovirus IgG and IgM positive, mostly IgG positive. If IgG is positive, then presence of pure red cell aplasia is extremely unlikely, and this is a mistake what many doctors don't realize, that the presence of IgG for B19 parvovirus is not the sign that patient has B19 parvovirus, but the sign that patient cannot have B19 parvovirus because patient is immune. However, presence of IgM alone indicates fresh infection in somebody who never had an infection of B19 parvovirus, but the most reliable test is B19 parvovirus PCR, where the virus is directly detected in blood. This test will allow us to distinguish B19-related parvovirus infection from idiopathic aplastic anemia, which is immune-mediated. As you can imagine, the distinction is important because if a patient has B19 parvovirus infection, you don't want to give patient immunosuppression, but you want to boost immunity by giving immunoglobulins. Conversely, in those patients who have idiopathic pure red cell aplasia, the treatment would be immunosuppressive agent. Now, I want to say mechanistically for those who are interested that we believe that pure red cell aplasia is mediated by T cells, not by B cells, which recognize erythroid precursors because of autoimmunity and because, for example, there is a cross-reactive virus or antigen that immune system cannot distinguish the bad guy from a good guy, and or because there are some other modification of the antigenic structure of the structures that the immune system recognize on red cells, and therefore red cell precursors, the cells that produce red cells, are specifically and selectively targeted by our immune system. Similarly, like during rheumatoid arthritis, the T cells attack our joint. In pure red cell aplasia, in idiopathic pure red cell aplasia, the most common form of this disease, we believe that the T cells recognize structures on our own red cell precursors, erythroid precursors, and kill them, therefore causing selective destruction of these precursors and anemia versus other lineages such as neutrophils and platelets remain normal. Okay, so this process is mediated by immune cells called T lymphocytes. Now, this is once more to allude as to the mechanism. We believe that these T cell responses, when they are triggered in a pathologic fashion, would lead to selection of T cells that specifically recognize, or T cell type that expands, if you wish, a T cell family that expands and selectively recognizes our bone marrow cells. If one happens to be a patient who carries T cells which recognize stem cell, then this patient would develop aplastic anemia and all lineages would be down. If patients' immune system recognize myeloid cells, then he would develop idiopathic neutropenia, or if, in our case, in pure red cell aplasia, the T cells would recognize normal erythroid precursors causing pure red cell aplasia. So this is the mechanism, if you wish. Our immune system does not distinguish good guys from bad guys and gets confused and eliminates red cell precursors considered either foreign or bad guys or worthy or needed to be eliminated, a hallmark of autoimmune diseases, similar into other immune diseases, autoimmune diseases such as rheumatoid arthritis or lupus or psoriasis, where the target cells are in the spleen. Now, I want to speak as to a special form of pure red cell aplasia, which is relatively common among cases of red cell aplasia, which is LGL. LGL is a lymphoproliferation of these lymphocytes, of these immune cells, that is almost acts like a lymphoma. These lymphocytes can be recognized easily by diagnostic flow cytometry, as alluded before, and they have clear morphology. They are called so-called LGL, large granular lymphocytes, and we believe that these are just crazy immune cells that recognize red cell precursors selectively and kill them, and therefore, in order to produce remission, these abnormally acting immune cells, cytotoxic T cells called LGLs, should be eliminated. Now, if you wish, the immunity is our friend. It protects us from tumor cells, it protects us from viruses and infections. However, in certain circumstances where these immune reactions, which are directed towards host defense, go errant, go wrong, then it comes to a pathologic destruction of certain tissues. In this case, LGL can be associated with pure red cell aplasia because these abnormal immune cells selectively recognize and go after erythroid precursors. Now, the most important thing is once we establish that this is pure red cell aplasia, either due to idiopathic form or due to LGL or associated with autoimmune, with immunodeficiency or associated with thymoma or other conditions, we have to devise a good treatment. Clearly, if pure red cell aplasia is due to B19 parvovirus, the most important is to treatment of B19 with immunoglobulins, which works 100% at the time. So B19 parvovirus in pure red cell aplasia is important to recognize because it's easily eliminated by infusion of immunoglobulins by your doctor, and this is important to recognize it because immunosuppression would not work in this case. Okay, as opposed to other special type of pure red cell aplasia, for example, in pure red cell aplasia associated with thymoma, we refer patient to cardiosurgery in order to remove the thymus to chest surgeons, which makes the treatment of pure red cell aplasia easier and sometimes causes remission of this condition. It is important to recognize cases which have LGL because LGL is treated with certain immunosuppressive agents, including cyclosporin, Cytoxan, methotrexate, Campas or ATG. The abnormal LGLs appear in blood and can be fought, and they, if eliminated, then the bone marrow starts producing red cells. And of course, primary idiopathic pure red cell aplasia is treated with multiple different drugs. I listed them here in a succession. I would use them in a typical pure red cell aplasia, including cyclosporin, together with prednisone, and of course, patient on cyclosporin should be administered magnesium because cyclosporin causes magnesium loss, and patients feel very bad with low. One should monitor reticulocytes count, and when the cyclosporin starts to work, the reticulocyte count will go up before even hemoglobin improves. The other agent used mostly by me in elderly or in older folks is Cytoxan. Works similar to cyclosporin. Sometimes it's better tolerated. However, it can suppress the bone marrow. Cytoxan by itself is anti-cancer agent, and therefore I don't want to use it in younger people because, like many other anti-cancer agents, they by themselves could cause other cancers. So we want to avoid it in younger people and prolong administration. The drug is relatively safe if given over shorter periods of time. We are talking months, but not over years. And particularly if there is a big latency of maybe 10 to 20 years, and therefore in older folks, it's probably very safe to administer Cytoxan. Okay, during Cytoxan administration, we should watch that Cytoxan does not suppress other counts, including platelets or white cells. Now, if these two drugs did not work, there are other agents, ATG being one of them. It's of course drugs that require submission, and it's more serious agent, but it has been used in pure red cell aplasia, and of course we use it very often in aplastic anemia. The other agent is Campas. Campas is a monoclonal antibody that is currently FDA approved for treatment of multiple sclerosis. However, under circumstances, your doctor can obtain it for you on compassionate base, and Campas should not be given in high doses but in small doses. Many doctors don't like to use it because they have made bad experience with Campus because it was used to treat leukemias at very high doses. Needless to say that for leukemia we used Campus at doses of 90 milligrams per week, but for pure red cell aplasia we would use it at the dose of 10 milligrams a week. In old days we infused it IV, but now these days we do only some small sub-Q shot under the skin, and patient tolerate it well. This would be alternative treatment to ATG that would not require hospitalization, but I have to mention that this drug is not FDA approved for this condition. Now, if this doesn't work, there are other agents that constitute, if you wish, third-line therapy, including anabolic steroids, which are male hormone, which under circumstances might help. Finally, in patients for whom nothing worked and who don't want to remain transfusion dependent, a patient can receive hemopoietic transplant. In my experience, I would like to try most of the other agents before I send patient for transplant, because transplant by itself is a very serious procedure which can have significant toxicity, including there is a small chance of dying from the transplant, and therefore I would rather use other methods first before I send patient for transplantation. Finally, in certain circumstances, if we detect that the patient has MGUS, this monoclonal gammopathy of unclear significance, or myeloma and pure red cell aplasia, one could try drugs which treat myeloma or MGUS, including Velcade. In patients who have low immunoglobulin levels, one would substitute immunoglobulins with immunoglobulin infusion, a measure that would also allow you to safer administer other immunosuppression, because immunoglobulins would substitute the deficiencies that the patient has. Now, I think I spoke already to this as to special thymoma. We need to remove the thymoma. Hypoglobulinemia, I just mentioned that in these cases I like to substitute immunoglobulins, particularly if immunosuppression didn't work. LGL leukemia is treated pretty much similar to pure red cell aplasia, but one has to be aware that this is a primary condition. And finally, it's important to mention that for those patients for whom all this measure did not work and who are not undergoing bone marrow transplantation, it is important to institute iron chelation. Personally, I don't institute iron chelation in older patients who are 70 and older, or rarely, because iron chelation or iron overload because of blood transfusion, of course, is toxic, but the toxicity is delayed over years. And these drugs themselves are not benign. However, in younger patients who are committed to transfusion for long periods of time, the iron will accumulate and cause organ toxicity, including heart failure, liver problems, and renal problems, joint problems, and many others, diabetes, and therefore needs to be treated. We have several iron chelation agents, including Exjade and Jadenu, which are the novel agents. Feriprox is available only in Europe. Is, in my opinion, best tolerated drug, but is not FDA approved in the United States. And of course, we have Desferol that has disadvantage because it has to be administered via pump 5 days a week over infusion under your skin. So it's difficult. It has to be managed. The company supplies patient with this pump, and it's infused under the skin. Now, for patients who don't tolerate cyclosporin, Prograf can be used, or if both either Prograf and cyclosporin are not being tolerated, then one could consider Campus, because Campus by itself, albeit not FDA approved for this condition, because it's such a rare, most of the drugs are not approved for this condition. The treatment of pure red cell aplasia is mostly based on empiric experiences. However, Campus does not have kidney toxicity and sometimes might be helpful of patients in whom you cannot give cyclosporin. With this, I will stop and I will ask for questions.
All right, thank you, Dr. Maciejewski, for your very informative presentation. We did get quite a few questions. First question comes from Jonathan. And Jonathan has a 7-year-old daughter who was diagnosed with PRCA in April last year with a hemoglobin level of 4.2. All obvious causes of PRCA were ruled out, including parvo and other viruses, as well as autoimmune issues, genetic causes. He had a number of transfusions last year, around 5, but became transfusion dependent this year, having a transfusion of 1 unit of packed red cells every 2 to 3 weeks. She has usually dipped to between the 6 and 7 range before getting another transfusion. She is scheduled for a bone marrow transplant as soon as they find a suitable donor. However, her last transfusion was on August 8th, so she has been transfusion-free for 8 weeks. Her hemoglobin dropped from 10 to 8 a week ago, and it is currently on 7.7. Jonathan is asking if this is a remission and how long this is likely to last, and what can cause her hemoglobin to remain so high after a period of regular transfusions. He also concludes with asking, should they be rethinking a bone marrow transplant?
Well, how old is the patient once more?
7 years old.
7 years old. Well, again, in children, the biggest differential diagnostic problem is, of course, to find out whether a child does not have one of these congenital bone marrow failure syndromes, including Diamond-Blackfan anemia. So it is very difficult for me to judge whether or not patient was tested for the presence of Diamond-Blackfan anemia or other congenital bone marrow failure syndromes. Now, Diamond-Blackfan anemia responds to corticosteroids or anabolic steroids usually, and in which case, depending on the quality of response or on the dose of corticosteroids, drugs like prednisone, that is needed to maintain hemoglobins, one would decide whether bone marrow transplant is warranted. But the decision for bone marrow transplant is, of course, very complex, and clearly improvement of counts spontaneously without bone marrow transplantation is a very good sign that would clearly ask for once more reconsideration of the whole strategy. Now, the other problem is, of course, that I don't know whether the patient received any treatment for once we rule out autoimmune congenital bone marrow failure syndrome such as Diamond-Blackfan anemia, whether the patient received any immunosuppressive treatment. So it's difficult for me to give a specific answer because it seems that this is a very complex decision, but I think, before bone marrow transplantation is triggered, one would have to think twice about it, assessing the current situation, including the viability of the donor, the quality of the donor, and ability to maintain hemoglobin without transplantation.
Okay, thank you. Our next question comes from Newton. And Newton was diagnosed with MDS 4 years ago. The most critical issue was his white blood cell count was around 1.5 with a hemoglobin level around 9. Starting a year ago, the hemoglobin started going down to 7, at which he received 2 units of transfusion. Since that time, his transfusion interval has fallen from 4 months to 1 month. He is asking, might this be PRCA?
Well, I think, as alluded in my talk, you would have to see first how high are retics, and if reticulocyte count is 0 or close to 0, then, of course, theoretically, puret cell aplasia would be in the differential. Now, I have to mention so that the pure red cell aplasia by itself is very uncommon, and thus there are many other reasons why the retic count could be low, but this would be the first distinction that I would make. Now, if we rule out all the other things as I mentioned in my talk, then one probably would perform a bone marrow biopsy and see whether erythroid precursors are present or not.
Okay, thank you. Our next question comes from Mary, and Mary is asking, is pregnancy safe for PRCA patients? If not, what are the risks to the mom and the baby?
I'm sorry, could you repeat the question?
Sure. This question comes from Mary, and she is asking, is pregnancy safe for PRCA patients? If not, what are the risks to the mom and the baby?
I'm still not sure about, is it the patient develop pure red cell aplasia during pregnancy, or is pregnancy a risk for developing a pure red cell aplasia? What is the question?
This question is just asking if pregnancy is safe. I guess if they're planning to have a baby and she may be diagnosed with PRCA, she's asking if it's safe.
For a young woman who is diagnosed with pure red cell aplasia, obviously all the other workup needs to be done in order to assess the nature of pure red cell aplasia, in particularly ruling out B19 parvovirus, which causes hydrops fetalis and causes fetal malformation. But the pure red cell aplasia, if a patient has chronic pure red cell aplasia that is not related to B19 parvovirus, of course, the pregnancy will complicate things a lot. But having said that, there are ways to carry the patient into terms through transfusion and limited treatments during pregnancy. But by itself, I don't know of cases in which pure red cell aplasia was triggered by pregnancy. Maybe it's possible, but I just have not observed cases like this.
Okay, thank you. Our next question comes from Alan, and Alan is asking, is it safe for PRCA patients to receive the flu and pneumonia vaccines? And if so, are these vaccines recommended? They're also asking, what about the shingles vaccine?
Yeah. Well, I mean, the shingles vaccine works usually when patients have normal immune system. And if patient receives immunosuppressive treatment or have low immunoglobulins, then the shingles vaccine using a live virus, attenuated virus, would not be indicated. In terms of flu vaccination, I think it's reasonable to get vaccinated. There is no direct association except for maybe 2-3 patients across many others that I have seen who felt that there was a relationship. But again, people get the vaccine and very few cases of pure red cell aplasia are present. But it has been brought up to my attention under circumstances, in which case, of course, the question is if patient is receiving immunosuppression, whether vaccination will be effective or not.
Okay, thank you. Our next question comes from Ron, and Ron is asking, have you considered establishing a registry for those with PRCA? Would we have to be your patients in order to join?
Well, yeah, no, absolutely. I mean, the problem is that, these type of registries are usually, it's a work of patience, and it's difficult to, it would be very, very helpful to accumulate knowledge about this rare disease to be able to give better recommendation and have systematic examination of treatment results of many patients, a presentation, association, complication, etc. Now, a registry like this has to be, there is a cost involved, and one would have to see from where, either write an NIH grant or support a registry like this from other resources would be very, very good idea. So yeah, it crossed my mind many, many times. I try to collect as many patients with pure red cell aplasia as possible. Having a systematic registry would be the way to go. But how to get it accomplished is the question. But yeah,
right.
One seed it somehow and try to get money from NIH, or one could ask Aplastic Anemia and MDS Foundation for support.
All right, thank you. Our next question comes from Kate, and Kate is asking, is there a time limit that cyclosporine remains effective?
Well, some patients develop a condition which I call cyclosporine dependence. In other words, when you try to taper off the cyclosporine, the disease comes back. There usually is a number. This number, if identified, the dosing of cyclosporin has to remain above it, above this number. But the tendency is that if patient had a full response, then one to try back off slowly from cyclosporin to determine what is the lowest amount of cyclosporin needed to maintain remission. Once the remission persisted over a long period of time, one could sort of institute another attempt to sort of withdraw cyclosporin based on a slow taper.
Okay, thank you. Our next question comes from Sam, and Sam is asking, I've noticed that some people originally diagnosed with PRCA end up really having myelofibrosis. Is this a misdiagnosis or a result of PRCA or another autoimmune disease?
Well, it's interesting. I did not mention it in my talk. My experience is, to be honest with you, I have not seen this type of association. I have heard that people mention it, but, obviously in patients with myelofibrosis, at the beginning, patients have reticulocytosis, so they have the opposite condition as pure red cell aplasia, and then when myelofibrosis reaches so-called spent phase, then is where the reticulocyte count drops. So whether pure red cell aplasia is not really, in my view, a complication of myelofibrosis, it would rather indicate that original myelofibrosis has been misdiagnosed, unless there are really special circumstances.
Okay, thank you. This next question comes from Joel, and Joel's asking, can you give a simple explanation of the STAT3 mutation and how it relates to PRCA and or other autoimmune diseases?
Which mutations?
The STAT3 mutation.
The presence of STAT3 mutation implies to me that patient might have had, in fact, pure red cell aplasia due to LGL. So STAT3 mutations are not really associated with pure red cell aplasia, are associated with LGL. And LGL, 10-20% of patients with LGA develop pure red cell aplasia type of picture. So the importance of it is that if you find these mutations, then it's pretty clear that patient, in my opinion, had LGL. And it clearly clarifies the causes for red cell aplasia, for pure red cell aplasia. This mutation essentially makes the lymphocytes, these LGLs, the soldiers of the immune system, immortal, and therefore those who recognize wrong targets cannot be eliminated. Causes pure red cell aplasia.
Okay, thank you. Our next question comes from Time, and he has a friend that has received ATG treatment the first week of August. He is wondering how long the dizziness, tiredness, and headaches should be lasting, specifically the dizziness. Can this become permanent? He has stopped cyclosporine and is tapering with prednisone.
Well, I mean, ATG comes with prednisone. Prednisone has to be tapered off within probably a month or so, 3 to 6 weeks. And by itself, ATG does not cause headache. It is that patients might not feel well during the initial period because they experience so-called serum sickness. By a month to 6 weeks after ATG is out of your system, and because it's a natural substance and not a chemical, really there shouldn't be any side effects from ATG. The symptoms could be due to anemia, or could be due to other drugs that were given with ATG, or due to prednisone.
Okay, thank you. This next question comes from Tina, and Tina's asking, what do you recommend to do about iron overload when all 3 chelating drugs cause the platelets to drop off, therefore needing a transfusion of platelets?
Well, it's difficult. One can try smaller doses. I did not encounter drop of platelets with ferritin, to be honest with you. So, but of course, ferritin is giving either sub-Q, which is difficult to administer, and the drop of platelets due to the other oral agents is well described. Now, one could, of course, if there is therapeutic decision, what drug do I use? I always prefer to use the drug that would get rid of the disease rather than get rid of iron overload. So, I mean, the emphasis should be set on treating red cell aplasia and then treating iron overload, in my opinion. Now, having said that, if we are dealing with diamond blackfan anemia, of course, the iron chelation is very important early on.
Okay, thank you. Our next question comes from Lori, and Lori is 30 years old. She had PRCA since the age of 13. She's never been in remission, and she tried CAMPAS recently. And since doing the CAMPAS, after she finished treatment, her platelets have dropped in the 50s 3 times, but went back to normal. And she normally goes every 3 to 4 weeks with needing a blood transfusion. Just recently, she was having to go in for 2 weeks for a transfusion, and she finished CAMPAS in May. Is CAMPAS still in her system, or is her bone marrow changing? And need another bone marrow biopsy?
CAMPAS usually don't last this long. CAMPAS by itself is rarely associated with thrombocytopenia. There can be a transient thrombocytopenia, usually comes back. Of course, CAMPAS is a serious drug and is given usually when other things, in my opinion, have been tried and failed. Therefore, of course, the CAMPAS administration is prompted either by persistent refractory disease or by worsening of the disease. So I would have hard time 6 or 5 months after administration of CAMPAS to attribute low platelet count due to CAMPAS. Now, having said that, CAMPAS causes profound immunodeficiency and sometimes causes CMV infection, so it would be important to check the patient for the presence of CMV infection. And of course, the doses would be also indicative whether the patient receives really a small dose or a big dose, which in my opinion not necessarily would be the best thing to do, because CAMPAS is better administered in small doses over a longer period of time rather than one big blob.
Okay, thank you. We just have a few more questions. This question is from Tina. She actually has 2 questions. She would like to know if you can explain the difference between PRCA and anemia.
PRCA is a disease, anemia is a symptom of, as a sign of, or the name for having low hemoglobin or low red blood cells in blood. So pure red cell aplasia is one of the reasons one patient might have an anemia, but if you take a garden variety situation patient, pure cell aplasia would be one of the most uncommon reasons for anemia. So in other words, anemia is far more common than pure cell aplasia, and most of patients with anemia will never have pure cell aplasia. They have other conditions, iron deficiency, vitamin deficiencies, other diseases of the bone marrow, anemia of chronic disease, etc.
Okay, thank you. And Tina's also asking if they're interested in possibly seeing you or scheduling an appointment with you. What is the best way to communicate with you about that?
Well, absolutely. I mean, if you call my office and they will direct you what to do, there is a central line that will make an appointment or facilitate everything. Ultimately, it will go through my office, but if you call my secretary at 216-445-5962, she will direct you how to go through the clinic because of the paperwork needed, which my office does not do because everything is centralized.
All right, thank you. And I would also like to add that anyone that's tuning in right now, you can definitely contact their patient educator, and she can be reached at HELP, that's HELP, at AAMDSIF.org, and we can definitely also help you with that process and getting in contact with Dr. Maciejewski. I believe, no problem. I believe that is all the time that we have for today's webinar. Once again, thank you, Dr. Maciejewski, for your wonderful presentation and for your time. I would also just like to add that if you would like to rewatch this webinar at a later time, please be on the lookout for an email that will provide you with an archive link in 4 to 7 business days. On behalf of the Aplastic Anemia and MDS International Foundation, I would like to thank each and every one of you for joining us today and making us your resource of choice for information on bone marrow failure diseases. If we were not able to answer your question today, please send it to us via email at help, that's HELP, at AAMDS.org so that our patient educator can respond, or visit our online academy at AAMDS.org/learn for interviews with experts and other programs that may address your question. As a reminder, as soon as I'm done speaking, a post-event survey will appear requesting your feedback. We appreciate your time to complete this survey. Again, thank you for joining us. And remember, learning is hope. This concludes today's program.